So patients who get stented with coronary stents are required to take dual antiplatelet therapy to prevent complications such as stent thrombosis. We don't know what the proper duration of therapy is. We conducted a large-scale randomized trial and published earlier this year which suggested that patients who are continued on 30 months of therapy have reduced rates of stent thrombosis and myocardial infarction in follow-up compared to those patients who receive only 12 months, which is the current guideline recommendation. So for this study, what we wanted to do was understand whether or not patients who were initially presented with acute coronary syndromes, heart attacks, had a different benefit or risk compared to those patients who underwent stenting in more stable conditions. We found out that continuation of dual antiplatelet therapy for patients with acute coronary syndromes or stable coronary disease both led to reductions in stent thrombosis and myocardial infarction, significant reductions. In both patient populations, it also increased rates of bleeding. But we think that the results, the decreases in the ischemic complications of heart attacks and stent thromboses exceeded the potential harms associated with increased bleeding. The purpose of this analysis was to see if that single sort of characteristic of presentation with acute coronary syndrome might define a patient population which might have greater risk and less benefit. It does look that as though patients who have acute coronary syndromes do have a greater benefit than patients who have stable coronary disease. Nonetheless, the benefit was observed in both groups. I think you're right that there are probably more individual types of patient characteristics that can define certain populations of patients who might benefit the most, or maybe certain populations who might be harmed by it, and that's stuff we're actively working on. Right now, the current standard of care is 1 year of dual antiplatelet therapy according to the guidelines after stenting. I think what these results should show, they should really change practice. I think the default should be a longer period of dual antiplatelet therapy in those patients who have gone a year and can withstood therapy without having any significant bleeding complications. Those patients should likely continue, whether or not they presented initially with an acute coronary syndrome. Yeah, I think that certainly any significant bleeding should prompt one to consider discontinuing. Certainly any bleeding within the first 12 months, that was actually a qualification criteria for the study. If you had major bleeding in the first 12 months, you weren't randomized. So those patients are not represented in the clinical trial. But if you reach a year, you haven't had any major bleeding, and then you continue therapy, I think it's great to continue to check in, ideally continue to check in with your patient, discuss the risks and benefits of prolonged treatment, and then make a shared decision with the patient. You know, there was this interesting signal among the non-acute coronary syndrome patients, which was an increase in death in those patients, and that was actually seen in the primary result of the clinical trial. That obviously provoked some consternation, so we took a closer look at what that was about. The obvious sort of explanation would be, well, more bleeding may be leading to more death. When we looked in detail in a blinded fashion, it wasn't actually bleeding that led to the death. It was deaths related to probably a chance imbalance in cancer between the two randomized arms. So we think that those findings are likely chance related. We're doing more analyses on those. So right now, that's our going hypothesis. Yeah, I think that there certainly are, you know, every patient decision needs to be individualized. There are certainly some patients who will say, no, I don't think that's right for me. That's why these discussions about the risks and the benefits are very important. And certain patients may have a greater tolerance for a certain risk, one risk versus the other. So whenever there's this sort of trade-off between risks and benefits, I think those are the types of situations where discussions with patients are really important. Well, I think that we need to better refine the personalized nature of our decisions. I think one step was looking at ACS, acute coronary syndromes, and non-ACS patients. The next step is thinking about more of a sort of multivariable stratification. So can I identify, you know, is it 75-year-old females who present with stable coronary disease and have a history of cancer? Is it those types of patients who really shouldn't continue? And is it, you know, 45-year-old men who present with ST elevation MI with no prior evidence for bleeding risk, that those patients who should definitely continue? That sort of individualized, tailored type of therapy is what we should, I think that's the data that we need. Those are the analyses we need to produce, and I think that's where the field is going to move toward.